Good morning. Welcome to the Department of Medicine Grand Rounds. Before I introduce Dr. Bowley to introduce our speaker, I have a few announcements. Number one, I know that many of you heard that in some publication, Louisville was labeled the top destination for travel for 2013.
Lonely Planet.
I'm sorry?
Lonely Planet.
Lonely Planet. Interesting. Second, some of you have heard a couple of months ago that the sleep center was going to be closed at the hospital. That is not the case. I will remind you that the sleep center, the sleep program, the training program are key for the pulmonary division and for its training educational didactic programs. And we have basically taken over the sleep laboratory, and starting effective this next week, the Department of Medicine will start administering that laboratory, and we'll make it more efficient yet, and we've identified a number of ways to do that. Some of you may have seen this publication from the American Cancer Society. I'm sorry, it's a little far away, but if you know her, that's Dr. Tara Schottmeyer, who's part of our department and who has a whole several pages of what she does. And I've learned more about what she does by reading this than by talking to her. But she's a grant-funded individual for the American Cancer Society, doing a lot of work in that area. If you see her in the hallway, tell her that I showed her to you. Dr. Barbara Casper gave me a list of where our residents are going to go for fellowship. And that's excellent. Every year the residents are doing extremely well. Some of them are going to U of L Cardiology, GI, Pulmonary Medicine, as well as Ohio State, University of Minnesota, University of Kentucky, Ochsner Clinic, Baylor, Case Western, Mount Sinai, Indiana University, and Louisiana State University. Everybody got what they wanted, and we're very pleased with that, which speaks about the caliber of our residency program. Next to final, Dr. Thorsten Luker. Is he around? So last year, Thorsten, one of our residents, won the first place for Young Investigator Award of the Southern Society for Clinical Investigation, and I just received a note from the Executive Director stating that again this year, in another abstract, Thorsten has gotten the first place for Young Investigator Award of the SSCI, looking at coronary vascular endothelial cells and how they may be protective for cardiomyocytes in the setting of reoxygenation, hypoxia, and so forth. So congratulations. Today is an interesting day for those who are ophthalmologists, because back in 1850, Hermann von Helmholtz, I think I said it right, presented to the Berlin Physical Society a new invention. And in fact, he wrote that later in 1851. He called it an eye mirror for the investigation of the retina and the living eye. He had invented the ophthalmoscope, which revolutionized, of course, ophthalmology and became very important also for our understanding of moving forward endoscopy in general. So that's important. I may have to leave you a little bit earlier. I've told the speaker, because this pager that you just heard is from the ICU at the VA, but I'll stay here as much as I can. And let me introduce Dr. Roberto Bowley, Chief of the Cardiology Division, who's going to introduce our speaker.
Thank you, Jesse. It's a pleasure to introduce our speaker today, Andy Lenneman. He's one of the newest additions to our family, one of the faculty we recruited in cardiology this year. Andy graduated from Wayne State University in 2004, did his residency in medicine at Vanderbilt, and then he became a hospitalist and an instructor in internal medicine at Vanderbilt. In 2008, he started a cardiology fellowship, and in 2011, he did a clinical fellowship in advanced heart failure and transplantation. We were very fortunate to recruit him last year to boost our burgeoning heart failure and transplantation program, which has grown tremendously over the last 4 years. The number of heart failure consults has quintupled in the last 4 years. Numbers of inpatients is growing, the number of outpatients is growing, the number of VADs is one of the highest in the nation, in the top 3 probably in the United States. And together with Emma Burks and Kelly McCants, Andy will continue to spur this meteoric growth of this really outstanding program, which is already a leading regional program, certainly the top one in Kentucky, and will continue to grow for years to come. So we are very pleased to have Andy here. He's an outstanding clinician and investigator. He has been trained in one of the best universities in the country, and we look forward to working with him and to his career development. Today he will discuss ventricular assist devices.
Thank you, Dr. Boley. Thank you, Dr. Roman. Thank you for having me. It's good to be here in Louisville, and Carrie and I have been very happy since we moved here, so it's nice to be here. Today we're going to talk about the treatment of advanced heart failure with ventricular assist devices. This is a map showing the number of deaths throughout the country related to heart failure. And you can see here in Kentucky that we're right smack dab in the middle of the heart failure belt. Particularly in the southeast, there's an immense burden of disease of heart failure and a very high number of deaths. So we have a long way to go in treating heart failure in our community. And you wonder why that is. Well, this one is for Dr. Boley. So a heart failure patient in Italy, Dr. Boley may have seen, might look like that. But you see here in Kentucky, we have a little bit different body habitus, and this is, really goes to show we have a high number of risk factors in our patient population, including obesity, hypertension, diabetes, all of which can lead to coronary artery disease and heart failure. So we have a long way to go again in treating our patients. But what does this all translate to? It translates into a very high impact on society, not just here in the Southeast, not just here in Kentucky, but across the United States. And so heart failure is one of the biggest diagnoses that is treated through Medicare, of course. Prevalence is almost 5 million patients, or over 5 million patients, with 550,000 new cases every year. Mortality as high as 50% every 5 years. 1.1 million hospital discharges per year, and this was 2010 data, at a cost of $32 billion annually. So in 2001, we changed the guidelines and changed how we look at heart failure to really refocus our attention earlier in the disease process. So in 2001, there was a category called Stage A heart failure, which really were patients who didn't have heart failure, but they were patients who had high risk but no symptoms. So we really wanted to refocus, and in Stage A patients, we concentrate on risk factor reduction, patient family education. We treat hypertension, treat diabetes at present, treat hyperlipidemia, ACEs and ARBs in our diabetic patients. But really, the categorization of Stage A patients is really to focus our attention earlier in the disease process and prevent the development of heart failure. Stage B, patients have gone on to develop coronary artery disease, or had an MI, or had some type of structural heart disease, whether it's hypertensive heart disease or ischemic heart disease. But these patients, should be treated with ACE inhibitors in all patients, and beta blockers in selected patients. Of course, if there's coronary disease present, that's when we would think of that. So once you develop symptomatic heart failure, then you're categorized as Stage C. Another thing that we want to focus on is that you can progress along the pathway of heart failure, but once you reach Stage C, you can't go back. And once you reach Stage B, you can't go back. So we really need to focus our attention on treating patients earlier. But once you develop Stage C structural disease, in the setting of current or previous heart failure symptoms, we really need to make sure to treat all patients with ACE inhibitors and beta blockers. Always remember that we have to do dietary sodium restriction, diuretics, and digoxin in selected patients, cardiac resynchronization therapy, if bundle branch blocks are present in selected patients. Some patients can benefit from valve replacement surgery or revascularization to help treat their heart failure. But as you progress along the symptomatic line of heart failure, it's important to consider a multidisciplinary team. At some point, we need to add aldosterone antagonists that have been shown to improve mortality. And then around 5 to 10% of patients with stage C structural disease with heart failure symptoms will go on to progress to stage D refractory heart failure despite medical management. And then you see how many steps we have along the process here in stage C heart failure. And the steps really run out once you get to stage D or advanced heart failure, which is refractory. We have continuous inotropic infusions, which the data for that has really, and we'll go over some of that today, but really has been pretty spotty in the past. Ventricular assist devices, which we're going to focus much of our talk on today, and heart transplantation. And of course, we can't forget about hospice. It's a very important part of what we do in advanced heart failure. So what's the prognosis of patients who, we know it's highly lethal. Many patients die within a year. We know that it doesn't travel alone. We know that heart failure goes along with lung disease, kidney disease, complications of diabetes and liver disease. It also carries with it a very poor quality of life, depression, chronic pain. Quality of life scores in our advanced heart failure patients are often similar to patients who have terminal cancer. So in the projected mortality of advanced heart failure, seen here, end-stage heart failure with optimal medical management, is as high as some of our most lethal cancers. So we really need to keep this in mind as we treat our advanced heart failure patients. So who is dying with heart failure? This was a study that looked at 160 deaths from 2000 to 2004 in Boston, and what we found, or what they found, is that 6 months before the death, these patients had acute on chronic renal insufficiency, they had hyponatremia, they had anemia, they had a reduced left ventricular ejection fraction, and 53% of them had right ventricular failure, which we know goes along with multi-organ failure. 42% of these patients, 6 months before their death, had greater than 2 hospitalizations. So we need to identify stage D or advanced heart failure patients, and how do we do that? Well, from using the data from some of these other studies, we can look at recurrent admissions, symptoms that are refractory to medications, increasing diuretic doses, or very importantly, when patients become intolerant to ACE inhibitors and beta blockers, this is a real red flag for us. We know that there's a significant mortality benefit from treating with ACE inhibitors and with beta blockers, and when we start to have to pull back on these therapies that we know work and we know improve mortality, that can be really a dangerous situation. Other things to think of, hypotension is a very dangerous sign that we see. Chronic renal insufficiency, hepatic dysfunction, hyponatremia, pulmonary hypertension and RV dysfunction, and then no response to resynchronization therapy also. And really, we need to refer to advanced heart failure centers earlier, before the signs of end organ dysfunction from heart failure develop. So how do we treat advanced heart failure? Well, like I said before, our options are limited. Well, we can whip the horse, we can give inotropes, and the horse is already walking uphill, and here we're going to ask a damaged myocardium to work even harder. Well, we can try to unload the wagon with afterload reduction, or slow the horse with beta blockers, or we can get a new horse and have a heart transplant. We can get a tractor, have a ventricular assist device, or we can work to heal the horse in myocardial recovery, which we'll also talk about a little bit later. So I want to really focus today's talk on mechanical circulatory support and ventricular assist devices, and we'll talk a little bit later about a bridge to transplant, and then also something that's emerged in the last 10 years or so called destination therapy, which is patients who are not candidates for heart transplant for one reason or another, really can be implanted with a ventricular assist device as their definitive heart failure therapy. Heart transplant has been around since 1967, and we've gotten very good at heart transplant over the past 40 years or so. But the candidacy for heart transplant is really limited. And then, of course, we can't forget about palliative care and hospice, and this is such an important part of the way that we manage patients. not every patient is going to be a candidate or even going to want the advanced therapies that we give or the life-changing therapies that we give. And it's important to know what your patient wants and to develop a relationship with that patient over time. And we can learn a lot from our oncology colleagues in this setting. So what happens to patients who are treated long-term with inotropes? We discussed inotropes a little bit earlier. This was a study that came out of Cleveland Clinic a few years ago, and it looked at 112 patients who were inotrope dependent with advanced heart failure. And you see these patients, well, they had some of those high-risk features that we talked about earlier. They had hyponatremia, they had chronic renal insufficiency. Only 34% of the milrinone arm was on a beta blocker. Roughly half of them were on ACEs or ARBs. And you see that their Lasix dose, their daily Lasix dose, was rising. And you see the mortality of these patients was pretty striking. The survival at a year in the milrinone arm was around 45%, and survival in the dobutamine arm was around 25%. Heart transplantation. Well, it certainly is a gift, and we've gotten very good at managing heart transplant patients. Now the median survival after a heart transplant is around 14 years. But remember, it's not a cure. We're trading one disease, heart failure, for another disease, chronic immunosuppression. And these patients, we develop a very close relationship with them over the years because they're in our clinic frequently, and we're adjusting their 8 to 15 medications. And remember, over the last 20 years, this is data from the United Network for Organ Sharing. Past 20, 25 years, there's been about 2,200 heart transplants performed in the United States on an annual basis. And despite all of our efforts to increase the awareness for organ donation, really, we haven't been able to increase this number above around 2,200. And with our increased number of heart failure patients, we don't have enough heart transplants to go around to all the patients that need it. And this is I know Dr. Roman likes to keep in mind the historical perspective, and the historical story of the heart transplant is really fascinating. But this was the Star newspaper from Johannesburg, South Africa, the day after the first heart transplant. It says, "The transplanted heart is beating." But right down here, it says, "Many problems to be answered." And I think this headline is true even today. Even though we've come a long way, we have many problems yet to be answered in caring for transplant patients. So now we're going to focus our talk, or the rest of the talk, really on mechanical circulatory support. This was the very first patient who was bridged to a heart transplant with a mechanical circulatory support device. This patient had essentially a total artificial heart where his left and right ventricles were removed and were implanted with a plastic and polyurethane heart pump. And you see all the apparatus over here that it took to care for this patient. This patient had that device for about 38 hours before undergoing a heart transplant, and he died about 60 hours after his heart transplant. But remember, this was in 1969, and a lot has changed since then. And Louisville actually has been a pioneer in VAD technology development. I don't know if any of you know this man, Dr. William DeVries, but he came to Kentucky in the mid-'80s and implanted the second Jarvik total artificial heart. It was right here in Louisville, Kentucky, and that patient lived about 680 days compared to that prior patient that I just showed you. Actually, the patient here in Louisville was the very first patient to leave the hospital with a total artificial heart. So let's talk about what the indications for ventricular assist devices are. Well, post-cardiotomy recovery, it's mechanical circulatory support for patients who are unable to be weaned from cardiopulmonary bypass, and this is after an open heart surgery. Of course, now we can have a ventricular assist device as a bridge to heart transplantation. And this has really prolonged the survival of patients who are on the heart transplant waiting list. Bridge to recovery, this is something that Dr. Burks has a lot of interest in, and this is something that we're still working towards as a field. But mechanical support, allowing patients to recover with sufficient myocardial function and to allow device implantation. And then, of course, there's destination therapy. This is mechanical circulatory support, ventricular assist devices, for patients who are ineligible for cardiac transplant due to age or malignancy or other comorbidities. And there is significant blurring between these indications nowadays. So we're less concerned with the indication. Now it's really focused on patient care. So let's review blood pump technology. First generation pulsatile ventricular assist devices, what's happened over the years since the 60s and the resurgence of the total artificial heart in the early 1980s, we went from, as a field, focusing on cardiac replacement to cardiac assistance. So you went from investigating total artificial hearts to looking at ventricular assist devices. And so the first generation of ventricular assist devices that came out were large and they were pulsatile. So the HeartMate XVE and the NovaCore device underwent clinical trials in the 1990s and early 2000s. The Thortec PVAD is still used to this day, and it's still used most commonly as a temporary assist device, as a bridge to either a more durable mechanical circulatory support device or as a bridge to transplant. The second generation devices, continuous flow pumps, came along because they're able to be smaller, and which it makes the operation shorter. It improves the durability of the device, and it also reduces the amount of stroke and infection. The most common device that we use nowadays is called the HeartMate 2. This was approved for use as a bridge to transplant in 2008 and then as destination therapy in 2010. And most recently, the HeartWare device, which is a third generation centrifugal flow pump, was just now recently approved within the past month for a bridge to transplant. Okay. So the Rematch trial was the very first trial to show a benefit of mechanical circulatory support, left ventricular assist devices, over optimal medical therapy. And this study looked at patients who were not transplant candidates, and it randomized them to optimal medical therapy with inotropic infusion versus mechanical circulatory support and assist devices. So you see that there was a significant mortality benefit. However, at 1 year, 20% of the optimal medical management arm, the inotropic arm, was surviving at 1 year versus around 50% of the left ventricular assist device arm. So this gave us a lot of hope as a field, but look here at 2 years. The survival is very poor. So even though this study was published in 2001, it gave us a lot of hope for destination therapy. Once again, these patients who enrolled in this study were not transplant candidates. But you could maybe buy that patient another 2 years before you started to have device failure, infection, stroke, all the different complications. So, we knew that we needed to update the technology, and over the years, the technology has really improved. From the HeartMate XVE, that was the previous trial, the Rematch trial, looked at the HeartMate XVE, and you see how large this device was. This is the inlet cannula going into the left ventricle here. Blood comes in, and this is a pulsatile device and ejects blood out that way to the ascending aorta. You compare the footprint of this device versus the footprint of the HeartMate 2. This is the most commonly used pump now. And this device is just below the diaphragm. Blood comes in this way, is pumped in an axial manner and out this way to the ascending aorta. You compare this device to the newest device that's been approved now, called the HeartWare LVAD. This sits actually directly in the pericardial sac. And the inlet cannula comes directly into the left ventricle, takes blood out of the left ventricle, and pumps it to the ascending aorta. And you see how small the pumps have gotten in the last 10 years. So it's important at this time to remember about our patients, the patients who we're taking care of, and the natural history of VAD-eligible patients treated with optimal medical management. This was in the Rematch trial. This is the Intrepid trial, which looked at the NovaCore pulsatile first generation left ventricular assist device. And again, the 1 year mortality in these optimally medically managed patients was really dismal. Let's talk about the next generation of pumps, which is the most common pump that's used today, called the HeartMate 2. The HeartMate 2 is surgically implanted in parallel with the native heart, native circulation. So the cannula goes directly into the left ventricle, takes blood out of the left ventricle, pumps it in an axial fashion through the pump, out the outflow cannula into the ascending aorta. You have a cord, or what we call a drive line, which exits the skin and is connected to a system controller. That system controller is connected to either external battery pack or wall power. These external batteries allow the patient to be free, untethered from the wall power for up to 12 hours or so. So again, the goal of the HeartMate left ventricular assist device is to unload the left ventricle. It can deliver about 5 to 10 liters per minute, so it can almost completely replace the circulation of the heart, but it does work in parallel with the normal native circulation. It's continuous flow. And so again, you're not going to have a pulse. The aortic valve rarely opens. We like to keep the aortic valve open, frequently, every maybe 1 in 4 beats, just so that you prevent fusion of the aortic leaflets. And with the changing technology, we've really come a long way as far as managing patients and as far as our outcomes have been. So you see down here the optimal medical management of the REMATCH and Intrepid trials, which we showed earlier, and then along came the publishing of the HeartMate 2 Bridge to Transplant trial in 2009. And you see the amazing impact that we've been able to have with this new technology on outcomes in advanced heart failure patients. So what happened in the real world? Well, this was a registry that was set up to look at all the patients who were implanted with left ventricular assist devices. And if you look at June 2006 to September 2010, here in red you have the pulsatile first generation pumps like the NovaCore device and like the HeartMate XVE, the pulsatile large footprint devices, and compared to the continuous flow devices. We see at a year in the continuous flow pumps, it was the 1-year survival was about 83% compared with 67% to the pulsatile devices. So this has really changed the way that we manage advanced heart failure patients. And you see here back in June of 2006, almost all the pumps that were implanted were pulsatile intracorporeal implanted pumps, which you see there was really less than 100 a year from 2006 to 2007. And then with the approval of the HeartMate 2 as a bridge to transplant, you start to see the rise of the HeartMate 2. Not only are the number of pumps that we're implanting across the United States increasing, but the field has almost gone entirely to continuous flow implanted pumps like the HeartMate 2 or the HeartWare device. And remember, it's not just about mortality. We want these patients to go home. We want them to live as normal life as possible as they can. So we have 6-minute walk distance improves. And these patients, at baseline, they're really New York Heart Association class 3 and 4, and by 6 months, many of them have New York Heart Association class 1 to 2 symptoms. 80% of patients will improve to New York Heart Association class 1 or 2. So we're making a significant impact on their quality of life as well. This was a patient I took care of in Nashville. His name is Pete Hutlinger. He's a professional guitar player, a studio musician, and he's played with many of the country artists that you know. He had advanced heart failure and was implanted with a HeartWare device in 2011. And despite being critically ill at one time with advanced heart failure, he was able to return to the stage. And this was a quote from his wife. Last week he was able to be up on stage, albeit briefly. This was something I wasn't sure I'd see or get to see again. So this was a picture that Pete sent us when he had an unsanctioned trip to Aspen, Colorado. Despite his pulmonary hypertension and despite his advanced heart failure after his device implant, you see he's carrying a little camera bag there, and that's the controls for his left ventricular assist device. So with this experience that we've had with the improved mortality after the FDA approved the HeartMate 2 in 2008, you see really over the last couple of years the number of pumps that we've implanted have skyrocketed. And with the increased number of ventricular assist devices that are being implanted, a national registry was created called the INTERMACS Registry, the Interagency Registry for Mechanically Assisted Circulatory Support, or INTERMACS. And this is supported by the NHLBI, the FDA, and the Center for Medicare Services, and it's maintained by the University of Alabama. What INTERMACS did was they further stratified and came up with a new classification system to discuss advanced heart failure patients. So they have 7 INTERMACS classes. Of course, they take, class 3B is INTERMACS 7, and then they take New York Heart Association class 4 patients and further divide them into 6 categories, okay? And so your INTERMACS 5, 6, and 7 categories are going to be your more well patients. The New York Heart Association class 3B, INTERMACS 6 is the walking wounded, and 5 is housebound. As you go down, the patients are getting sicker. So INTERMACS 3 and 4 are maybe the frequent flyers, multiple readmissions with heart failure. INTERMACS 3 is now inotrope dependent patients who are stable. But INTERMACS 3 to INTERMACS 2 are these patients who are what we call sliding fast, or they're developing end organ sequelae from their advanced heart failure. And then INTERMACS 1, the sickest patients, are your so-called multi-organ system failure, cardiogenic shock patients who are crashing and burning. These are really your most critical patients. And INTERMACS 1 and 2, so the sickest patients really account for about 70% of our ventricular assist device implants. Okay. So what happens? Well, these INTERMACS 1 and 2 patients, these patients are very sick going into surgery, and because they're very sick going into surgery, you see that there's a very high early mortality. But if you compare INTERMACS 1 and 2 patients, the very sick multi-organ system failure patients, compare that to INTERMACS category 3, which is stable inotrope dependent patients who have advanced heart failure. These patients do much better after left ventricular assist device implant. And they also have a shorter post-implant length of stay. So timing of LVAD implantation, this is something that we struggle with as a team almost on a daily basis. So there comes a time in the progression of somebody's heart failure where they're going to get worsening of their nutritional state, worsening end organ function, worsening right heart dysfunction. And as they go along this process of their heart failure, their operative risk also increases. And there's going to come an arbitrary point here where your operative risk is going to increase so much that the patient's not going to survive the implant. And what we want to do is find where that point is and implant the ventricular assist device prior to them developing multi-organ system failure, because we know that sick patients going into surgery really don't survive as well, and that makes sense. So now we're going to talk about the structural and molecular changes that actually happen with ventricular assist device treated patients with heart failure. So the hypothesis was that if you unload a failing ventricle with a left ventricular assist device, it will restore the normal shape of the ventricle and lead to structural and molecular changes and serve as a platform for potential recovery from heart failure, which was previously thought to be an end-stage irreversible process. So you have a normal heart over here, and there's some myocardial injury that happens and leads to heart failure. So as the radius of the heart increases, as it becomes more spherical in shape, the wall stress inside of the ventricle increases, and so that causes hypertrophy of the myocytes in the heart muscle. And so what happens when you have a ventricular assist device in place? So here you can see this bright thing on echocardiogram is the inlet cannula right here inside of the left ventricle. And with the LVAD turned off, you see how big and dilated the left ventricle is. But then you turn the LVAD on and you see how small and elliptical, and the left ventricle, most of the time or many times, it returns to its normal elliptical shape. And this was a section taken from a donor heart. And here you see the normal small myocytes here with some interstitial connective tissue. But once you develop heart failure, you have these very big cardiac myocytes here. But what happens when you implant somebody with heart failure with a left ventricular assist device? You see that the myocyte hypertrophy regresses, but this interstitial fibrosis remains. So LVAD support reverses myocyte hypertrophy. And here you see sections of individual myocytes from donor heart, those with idiopathic dilated cardiomyopathy. You see how large and hypertrophied these cardiac myocytes are. And then after a ventricular assist device, well, the myocyte hypertrophy regresses. But there's at some point, when you get regression of myocyte hypertrophy, when does that become cardiac atrophy? And that's something that we work to avoid. So what happens hemodynamically? You see from cardiophysiology, this is a heart failure patient. You see how high the left ventricular end diastolic volume and end diastolic pressures are. Well, with ventricular assist device support, you get a drop of the left ventricular, the LV end diastolic pressure and volume. It decreases. Also, the peak systolic pressures decrease. So hemodynamically, after a VAD implant, you get improvement of the right atrial pressure. You get a drop in pulmonary hypertension or drop in the peak PA systolic pressures. You get a decrease in the pulmonary capillary wedge pressure with a modest increase in the cardiac output. So molecularly, what's happening with these patients? The mechanism of reverse remodeling is, this was a study that looked at 13 patients with a HeartMate left ventricular assist device, and what they found is at baseline, the plasma renin level was high, the angiotensin II level was high, the epinephrine level and the norepinephrine levels were high. But at explant, at heart transplant, what happened was that these levels had decreased. So following an implant with an LVAD, the Renin-Angiotensin II, epinephrine and norepinephrine levels improved. Beta receptor density also improved. So in a non-failing heart, this is the normal beta receptor density in the myocardium. In a failing heart, you can see that drops, and beta receptors are downregulated in heart failure. But with the addition of a left ventricular assist device, you get reversal of the downregulation of beta receptors. So this provided the impetus to look at if we could actually reverse the process of heart failure. And this was a study that was led by our colleague, Dr. Burks. And they looked at 20 patients with non-ischemic dilated cardiomyopathy who were implanted with a HeartMate 2 as a bridge to transplant. They underwent phase 1 of the trial, which was high doses of beta blockers, ACE inhibitors, ARBs, aldosterone antagonists, and digoxin. So all the good treatments for heart failure. They underwent rigorous testing with echocardiograms, exercise testing, and cardiac cath to monitor for improvement. And those who did improve were treated with clenbuterol. And this was added to promote physiologic hypertrophy because, as I said before, you do get regression of the myocyte hypertrophy, but at what point does regression of myocyte hypertrophy lead to atrophy of the myocytes? These patients, there were 20 patients who with dilated non-ischemic cardiomyopathy who were eligible for the therapy. 8 of these patients, despite treatment with neurohormonal blocking agents, did not recover, but 12 did recover and were explanted. 2 died post-explant, but 10 were alive as well. And of those 10 surviving patients, and many of them remain in New York Heart Association Class 1 and 2. These patients are still followed by Dr. Burke's colleagues over in England, and they're still doing well. Fibrosis at implant predicts myocardial recovery. So there have been many things that some of our patients with ventricular assist devices recover and some of them don't. And we've looked for characteristics of these patients that will help us predict who will recover and who won't. In this study, Group A were the patients who did recover, and Group B were those who didn't. And they looked at total collagen levels. So if fibrosis, at the time of implant was predictive of those patients who would and wouldn't recover. So we can use this, and this again gives us more evidence to try to treat heart failure earlier and prevent the development of fibrosis within the myocardium. Okay, so what is LV unloading with a ventricular assist device? What effect does that have on myocardial structure and function? And we talked about many of these things. Improved hemodynamics, it restores normal elliptical shape, it reduces hypertrophy, but the fibrosis remains. It improves the neurohormonal axis and improves beta adrenergic response. But despite these promising findings, there have been very low rates to date of sustained myocardial recovery because we really haven't looked at this in a systematic way yet. And so we here at the University of Louisville, led by Dr. Burks, we're looking at that very issue right now. Now ischemic VAD patients, many of them are screened for recovery now. We treat all of our patients with neurohormonal blockade early, and oftentimes titrating these doses even before they leave the hospital with their ventricular assist device. Then they undergo rigorous testing, and so far, since October 2010, under the leadership and guidance of Dr. Burks, we have explanted 12 patients. And you see the age range is from 19 to 67. So Dr. Burks has also led a national effort to study this in a systematic way, and she's started the trial called Restage HF, which we are the site and data coordinating center. And you see the Texas Heart, Cleveland Clinic, Pittsburgh, Michigan, Pennsylvania, and Montefiore are all involved. But we still have many unanswered questions. And what is the impact on patients and society? Who's gonna pay for this? We have a limited number of healthcare dollars, and despite the promising and excellent results that we've been able to get, this is going to be a limited resource. At this time, we have no treatment guidelines or best practice. We need to determine what the optimal LV unloading strategies are, what pump speed should we set people at, and what medical therapy should we use. And we haven't even talked about the complications of left ventricular assist device treatment, including bleeding, infection, hypertension, stroke, thrombosis, arrhythmia. And these patients are very difficult to manage, and it takes a coordinated effort from a large team of people to care for these patients. But even though it takes a coordinated effort, it's a very rewarding process to see these patients who've had advanced heart failure return to their life. And so this is a quote that pumps up heart failure cardiologists. Says, we choose to go to the moon in this decade and do other things, not because they're easy, but because they are hard, because that goal will serve to organize and measure the best of our energies and skill, because that challenge is one we are willing to accept, one we are unwilling to postpone, one which we intend to win, really gets us going. So, the prevalence of advanced heart failure is increasing, but cardiac transplant, it's the best test. We've had excellent results with it, but it's a very limited resource, and it's not going to be enough to manage all of our advanced heart failure patients who need help. VAD therapy is emerging, and we're getting a lot better at managing patients with ventricular assist devices, and pump technology continues to evolve and improve. And with that, we've had success in improving outcomes. We need to keep in mind to refer patients for mechanical circulatory support earlier in their disease process, before they develop multi-organ system failure, and before they're too sick to survive the implant surgery. Myocardial unloading with ventricular assist devices significantly improves myocardial structure and function, and we can use that information, that promise, to advance this field even further. And we have a lot to learn. I'd like to acknowledge Emma Burks and Kelly McCants really for helping to ease the transition coming here from Vanderbilt, and it's been a very good experience. Dr. Boley, thank you for recruiting us. Mark Wigger and Doug Sawyer are my mentors from Vanderbilt. I'd like to thank the VAD and transplant and heart failure teams here at UofL and Jewish Hospital. And I'd be happy to take any questions.
Thank you, Andy. That was a very informative session, very clear. So, there are only about 2,200 transplants a year in the US. That's not going to increase, and there are 5 million patients with heart failure, presumably many of them would benefit, at least much more than 2,200 would benefit from a transplant. So are we at a point where a patient could have a destination VAD in lieu of a transplant? I mean, what is the long-term outlook for somebody on a destination VAD as opposed to a transplantation? You said the median survival is 15 years, right, after transplantation?
14, yes.
14 years, right. So how does that compare to someone who cannot get a heart but receives an LVAD as a destination therapy?
Well, the data that we have for destination therapy, really, these patients are not, in general, not transplant candidates, so they're sicker going into the surgery. So their outcomes haven't been quite as good, but they've certainly been, the outcomes for destination therapy, I think, at a year nationally are in the 75 to 85% range of survival.
So it's a different population. These are sicker patients. And
yes, so they have other comorbidities that make them not a transplant candidate.
It's not a comparable population. Any questions?
Andrew, very nice lecture. Thank you so much. I have two questions. First of all, I have very little experience taking care of patients with LVADs, but I've had a lot of experience taking care of patients with pulmonary hypertension on Lowland. And while none of them was eager to die, they were relatively miserable people. They really didn't like being hooked up to these external devices.
Yes.
Implants and catheterization. So first of all, what's the quality of life for people on LVADs? And again, although nobody's eager to die, are they happy or unhappy with the treatment? And second, has anybody looked at patients with ischemic cardiomyopathy after revascularization and recovery of ejection fraction and cardiac function with LVADs?
So, in answer to your first question, the patients who are going into this surgery, are very sick and their quality of life is very poor. So the majority of our patients are quite happy to live with a ventricular assist device. They return home. Many of them actually return to work even. So, I mean, it certainly is an adjustment, and that's what I tell patients, that it's absolutely a life-changing procedure. And some patients, they don't want to be hooked up to a controller and batteries at all times. So it's certainly not a treatment that is for everybody, but in the right selected patient, it can really improve quality of life. And I think the best example of that we can see was Dick Cheney. He had a ventricular assist device, and he was able to, resume his life doing whatever it is that he did, and and he was very happy until he received his heart transplant. Yeah. And then, as far as looking at how ischemic patients recover, I think that's an area that we need to do further investigation. Yes.
Dr. Lenneman, you talked about optimizing the time of implantation and LVAD for successful outcomes.
Yes.
Do you have any objective criteria for that? Like when patients start failing asynchronously, is that the time to do it, or before that, how do you decide?
Absolutely, there are criteria for that, and it's I showed it earlier in that slide of as patients start to become, they have recurrent hospital admissions. Once they develop, signs of end organ dysfunction, acute on chronic renal insufficiency, hepatic dysfunction, signs of right heart failure, hyponatremia, anemia, all of these signs, lead us to, lead toward implantation. But, it's a very difficult question to answer, and that's something that we struggle with as a team, and I think all centers who take care of these patients struggle with the timing, and each patient is going to be different. Yes?
One of your slides showed experience with the HeartMate 2, I think extending out to 4 years. And I think that as time would go on, that's probably going to continue.
Yes.
What are you seeing in long-term, non-acute complications, kidney, brain, from either veterinary or human data?
Yeah, so there was a big concern about because now these are continuous flow devices versus pulsatile flow devices. So what would be the effect, on long-term cognitive function, on renal function with continuous flow circulation rather than pulsatile flow? So the biggest complication of that we've seen has been GI bleeding, and I don't know if we have any GI colleagues here, but we're constantly calling you to see our patients with GI bleeding, and that's probably related to the continuous flow circulation. But there have been a number of animal studies looking at renal dysfunction in patients with with continuous flow in animals with continuous flow circulation. And there's some periarterial changes that happen, or at least in some small animal studies. But overall, actually, with continuous flow devices, the rates of renal dysfunction and hepatic impairment have been lower than they were with the pulsatile devices. And that's probably just because of the improved technology that we have, the smaller footprint, the less risk of infection, and that kind of thing. Did that answer your question?
Yeah.
No, yes.
Thank you for your talk today and welcome to Louisville. I just had two questions. I wanted just to develop a little bit further on the quality of life question that Dr.
Yes.
asked. And that is, are you using any objective measurement tools to measure by the patient, quality of life, more specifically validated tools that are used in other studies? And can you comment on the research that's been done specifically about that? I'm assuming this is they're new and there's probably not a lot of numbers that there might not be, but that was the first question. Second question is, you mentioned how important the role is of hospital is.
Yes.
And I wonder what sort of training that cardiology fellows are providing to their fellowship programs, providing their fellows in hospital medicine, since you all seem to be providing a lot of primary palliative care, not especially the whole primary palliative care for patients.
So as far as how we assess quality of life, there have been a number of tools like the Minnesota Living with Heart Failure Scale, but I didn't know what tools you were speaking of in particular.
Such that I
Yeah.
just wondered if that's being used here, if you're measuring quality of life.
That's certainly something that we're looking into. Yes. And then as far as your second question, we don't really get formal training in palliative care. I think with our advanced heart failure fellowship, those are particularly the people who we would focus that on. And I know during my fellowship, I definitely was very involved with the palliative care team and the hospice team at Vanderbilt. And I rotated through their clinic, and I worked closely with them. So it's really, there's no formal criteria yet, but I think that's certainly an area for growth and something that we look into. Yes? Oh. Yes.
So what's the understanding of what's the basis for the fibrosis? And then goes with the necrosis factor activities in treatment of heart failure?
Well, that's still an evolving area, and that's a very difficult question to answer because there's been a lot of conflicting data from many small studies looking at fibrosis and heart failure, fibrosis after a ventricular assist device, and some studies have even shown after ventricular assist device is implanted that the fibrosis in the myocardium increases. There was a study published in JACC, a very small study, about a year ago that showed just that. So we have competing mechanisms at work inside of the heart, and I think we really have a lot to learn, and hopefully Dr. Burks' study will help to answer some of those questions. Yeah. Yes, I think L-dactone would be. There's been promising data with L-dactone, and I think earlier use of that would be. Yes, Dr. Ramirez?
You're saying a fixed pulmonary hypertension, and how does that affect your decision that
Well, say that again?
fixed pulmonary hypertension?
Yes.
How often are you seeing that? Does that play a role in your decision to?
Absolutely. I mean, there are so many of our patients who have pulmonary hypertension. Many of them have reversible pulmonary hypertension, and prior to implant, what we usually do is try to diurese them as much as possible to lower their filling pressures. And often with lowering their pulmonary capillary wedge pressure, you lower their mean arterial pressure prior to implant. But we also see that fixed pulmonary hypertension with a PVR of around 3 Woods units or even 5 Woods units, that over time can improve in many patients after implant. So it's certainly, especially here, is not a contraindication the way that it is with heart transplant. But we need to be very careful in that situation to help support the right ventricle, especially in the perioperative setting. Yes?
As a follow-up to that question, as a general interest, I've always been puzzled as to why L-lactose is so far up the ladder of the tractors. Does it work just for hemodynamics, or does it do other things, or should it really be that far up the refractory ladder?
Well, it's moving down in the ladder, and there was a study that came out in 2010 looking at eplerenone in New York Heart Association Class 2 patients before it had been reserved for patients with a low ejection fraction and New York Heart Association Class 3 to 4 symptoms. But with that, the most recent data that we have, I think you're absolutely right. I think that you get a benefit.
Far up because there were side effects, or just there was a desperation to do much? I mean, I always thought it, in the right patient, seemed to work.
Absolutely. No, I agree with you 100%. Yeah, I don't know why. I think it is because of the data that we had available. You know, the earlier trials were post-MI trials, and they were in patients who had heart failure after an MI, and they were New York Heart Association Class 3 and 4. But there have been new data that shows that even the benefit in New York Heart Association Class 2 patients.
All right, thank you very much.